Welcome. So, you're gearing up for your exams, or maybe you just want to make absolutely sure your practice is rock solid on compliance. Either way, you're in the right place. We're going to dive deep into the BDA's radiation protection guidelines, breaking down all the critical stuff, the things you really need to know to pass and practice safely.
Okay, so here's our game plan. We're hitting 5 key areas. We'll start with the legal stuff, then who's responsible for what. After that, we'll cover protecting your patients, protecting your team, and finally, we'll look at the quality assurance that makes sure it all works.
All right, Section 1, the legal framework. Now, if there's one thing that's almost guaranteed to pop up on an exam, it's distinguishing between the two big regulations. They're the pillars of everything we do, so let's get this locked in.
So here they are, side by side. It's actually pretty simple when you break it down. Think of it this way. IRR 99. That's for us, the staff, and the public. It's all about workplace safety, and the HSE is the one that enforces it. Then you have IRME, R2000. That's for the patient. It's all about their protection during a medical exposure, and it's overseen by bodies like the CQC. So IRR for the room, IRMER for the person in the chair. Get that difference down, it's a huge exam point.
Okay, so we've got the laws, but who actually does all this stuff? That brings us to Section 2, the key roles and responsibilities in your practice. Let's figure out who's who in the zoo.
First up, and this is the big one, we have the legal person. This is usually the practice owner. To put it simply, the buck stops with them. They have the ultimate legal responsibility to make sure the practice follows all the rules. They're the ones who have to set everything up and appoint the right people to the right jobs.
And when we say ultimate responsibility, this is what we mean. Look at this list. It's a lot. We're talking written procedures, training records, referral criteria, setting those all-important diagnostic reference levels or DRLs, you name it. Basically, the legal person is in charge of creating and maintaining the practice's radiation protection file. That file is the single most important document you have. It's your proof that you're doing everything by the book.
Okay, next up is the Radiation Protection Supervisor, the RPS. If the legal person sets the strategy, the RPS is the boots on the ground. This is someone in the practice, a dentist or a trained DCP, who makes sure that the local rules are actually being followed day in, day out. They're the go-to person on the clinic floor.
Now, here's a really important point. You're not expected to be an expert in physics or radiation law. That's why you must appoint external experts. You've got the Radiation Protection Advisor, or RPA, and the Medical Physics Expert, the MPE. The RPA helps you with the IRL 99 stuff, think equipment, risk assessments, staff safety. The MPE is your go-to for IRMER, so patient dose, image quality, that sort of thing. And yeah, they can be the same person, as long as they've got the right qualifications for both roles.
Okay, and finally, let's look at the clinical team. Under IRMER, we have two really distinct roles. It boils down to the why and the how. The practitioner, that's almost always the dentist, is responsible for the why. They are the ones who have to justify taking the X-ray in the first place. Then you have the operator. The operator is responsible for the how. This is anyone, and it can be more than one person, who carries out the practical side of things, from identifying the patient to positioning the film, hitting the button, and even processing the final image. So we know who's in charge. Now for Section 3, how do we actually protect our patients? This is all about the core principles we use every single day, and it all comes down to 3 key ideas: justification, optimization, and evaluation. And everything, absolutely everything, starts with this one question. Before your hand even goes near that exposure button, you have to stop and ask, is this X-ray really justified? And this isn't just about being a good clinician. It's a fundamental legal requirement. You see, justification isn't just a vague idea. It's a checklist you have to run through every time. You got to weigh the benefit versus the risk. You have to consider the patient's history. You absolutely must check if there are previous X-rays that would do the job. And ask yourself the critical question, is this actually going to change my treatment plan? And here's a massive, bold, underlined point for your exams. Just taking routine X-rays on every new patient before you've even done a clinical exam, absolutely not justified. Remember that. Okay, so you've justified the X-ray. What's next? Optimization. This is all about the ALRP principle, keeping the dose as low as reasonably practicable. So how do we do that? Well, it's about the simple, practical things.
always using the fastest possible sensor or film. We're talking e-speed or better. Using rectangular collimation is a huge one. It cuts the dose down massively. And of course, making sure everyone is trained up and following your written protocols and DRLs to the letter. Right, we've got the patient covered. Now let's talk about us, the dental team. Section 4 is all about staff and practice safety. We're going to focus on creating a safe environment, which really boils down to two big things: the controlled area and personal monitoring. Here's a number I want you to burn into your brain for exam day: 1.5 meters. That's it. That's the minimum size of the controlled area that exists around the X-ray machine and the patient whenever you take a shot. And inside that controlled area, the rules are simple and they are absolutely non-negotiable. Rule 1, only the patient. That's it. Everyone else needs to be at least 2 meters away to avoid scatter, and obviously nowhere near the primary beam. And you must be able to see both the patient and the warning light the entire time you're making the exposure. So, do we all need to wear those little badges? Not necessarily, but you have to know the rules because this is prime exam material. You are legally required to use personal dosimeters if any single person's weekly workload goes over 100 intraorals or 50 panos. It's one or the other. And if you are using them, those results have to be written down and kept safe for at least 2 years. Okay, our final section. Let's tie this all together with quality assurance. This is the part of the system that makes sure we're not just blasting away, but that every single exposure we make is a good one. It's all about making every image count, so we don't have to take repeats. A huge part of QA is actually grading your own work. Think of this as your practice's report card. Every radiograph you take has to be graded on this simple 1, 2, 3 scale. And you have to audit your results against the national targets. And yes, you guessed it, these targets are examinable. You're aiming for at least 70% to be excellent, grade 1, and no more than 10% should ever be unacceptable, grade 3 rejects. So what happens when you get a grade 3, an unacceptable image? You can't just toss it and forget about it. That's a huge no-no. You have to become a bit of a detective. You need to log it. You need to write down exactly why it failed, what you think the cause was, and of course, how many repeats it took. This isn't about pointing fingers. It's about spotting patterns. Is it a training issue? Is the equipment failing? This log is how you find out and fix it. Now, this might seem a bit old school, but if you're still using film, this is a classic QA test you need to know. It's the coin test, and it's a brilliantly simple way to check your darkroom for light leaks from the safe light. You basically expose a film to different amounts of safe light with coins on it, and the result is super simple. If you can see the ghost of a coin on your finished film, your safe light is fogging your images and you need to sort it out. You know, none of this works, none of the rules, none of the protocols, without proper training. And it has to be ongoing. The big number to remember is a minimum of 5 hours of verifiable CPD, specifically on radiation protection, every 5 years. And that's for every single duty holder. And remember, it's not a do it once and forget kind of deal. Training has to be part of the induction for all new staff, and you have to retrain whenever you get a new piece of kit. So let's end by bringing it all back to one simple and maybe slightly scary question. We've gone through the whole framework, but the real test, the thing that proves you're on top of all of this, is your radiation protection file. It's meant to be a living, breathing document. So ask yourself honestly, if an inspector walked through your door right now, this very second, is that file complete, reviewed, and ready to go? Because that's the standard. That's what this is all about.